to give our weekly to 2 weekly update on the London Primary and Community Care Resource Pack. This is the third webinar we have done. We won't be going through the whole of the resource pack, but highlight those changes that have been made. I will also be highlighting the common questions that have been asked within the last few weeks. So I'll hand over now to Dr. Mack, who will come up with his resource pack.
Good evening, everyone. Can everybody see the screen? I'm not getting any feedback. I can't see the chat, so the Q&A. So I hope that everybody is actually in. There were lots of queries about people joining at the time. So if any of you have been on the previous 2 webinars, you know that we generally begin the session by refreshing about what changes have been made to the Community Respiratory Resource Pack during the last couple of weeks. So I'm just going to, we're not going to go through the whole document because we've done that previously. We're going to now just give you the updates on what's really actually changed. You will see that the, if you can see my screen, the updated things for version 4 are in the change log there. So briefly, what we have mainly done is actually talk about, again, the people who have comfortable hypoxia. So we are asking people, we are saying again that a lot of patients out there sometimes have great difficulty in actually determining, we have great difficulty sometimes in determining who is actually quite ill. So therefore, oxygen saturations are very, very helpful in helping us determine who is actually very, very sick. The first diagram, this one here, the pathway diagram, has changed slightly. So what we have done here is actually talk about people who have advanced care plans or people who do not have advanced care plans and have a preference for admission to hospital. There may be some people that who may not have advanced care plans but actually do not want to come into hospital and want to be managed at home, in which case these patients may need a telephone or a video consultation or may need a home visit eventually. If that's the case, that the algorithm goes further on to discuss what we should do with those. But for ones that have advanced care plans, and also the more complex patients with comorbidities, they may also require a video consultation or a home visit if appropriate. But for ones that are clearly very sick, the ones that are with severe symptoms, it may be appropriate for them to go straight for admission to hospital. So this is a slight change from what we had before for the category 1 patients, because it just clarifies about the patients who do not have advanced care plans. There's been a slight change to the flow diagram in the pathway 2, and here we have introduced a desaturation test. We know that a lot of patients may have borderline oxygen saturations, and one of the most sort of discerning ways of actually deciding upon whether or not a patient is sick or not is actually doing an oxygen desaturation test. So here we're dividing, instead of having 3 categories now, we have a low to medium risk box and a high risk box. And you'll see that there is a slight overlap between the oxygen saturations. The borderline saturation, or the cutoff point, is around about 94%. We haven't been completely specific because we're actually asking you to actually go on what the patient in front of you is like. So the high risk group is saturations of 94% or less, who are not able to speak in full sentences, who are clearly unwell with other signs of sepsis or anything other that you will be concerned about, who would be appropriate for transfer to hospital. There may be patients who are sitting very comfortably at 94% and who may not have raised respiratory rates or be very tachycardic and able to speak in full sentences, who may need then a further assessment. And the assessments that we are suggesting is a desaturation test. This can be done in either two ways. You can either do a 40-step walk, a rapid 40-step walk, or you can do a 1-minute sit to stand, which means sitting in a chair and standing up and doing that repeatedly after a minute and see whether or not they desaturate. These tests are not actually haven't been developed for COVID, but these are the best things that we actually have in order to determine whether or not patients actually desaturate on exertion. So if there is no desaturation from 94%, then it's probably safe to monitor these patients at home with adequate safety netting. If they do desaturate, and again, the amount of desaturation will vary, and we would reckon that 3 or 4% desaturation is probably significant. And if you're not sure, then we would suggest that you actually confer with your colleagues or ring the hotline that we're going to talk about a bit later on to actually discuss the patient, because this is an evolving event, and therefore it's not always clear exactly which patients should actually come in all the time. And I think that sometimes it is worth a discussion as to which patients actually need to be brought in for a further assessment in hospital. We have modified slightly the pathways with pre-existing lung disease. So we've aligned the asthma pathway and the COPD pathways with the NICE guidance as far as we can. And we are advocating that patients with asthma and coexisting COVID, most of the time, COVID does not seem to be making asthma worse or precipitating asthma attacks. So people that are having an asthma exacerbation, generally this may be just an ordinary asthma exacerbation rather than something precipitated by COVID. And these patients should be managed by any pre-existing asthma management plan and either increasing their dose of inhaled steroids or given a dose of oral steroids if their peak flows are less than 50% of their normal predicteds. There is no harm in using oral steroids, even in the presence of COVID, because we're talking about very short courses in these situations. And in asthma, in particular, courses of oral steroids may be very important because they may be able to change the course of the disease. With COPD patients, again, if they are really bad and they have previous steroid responsiveness or an asthmatic tendency, then these patients would benefit from a course of steroids as well. And steroids should not be withheld in case of for fear of COVID in these patients. We talk about further on more detail about safety netting. We've given a little bit more guidance. In the low-risk patients, they can be given just general advice and to be advised to call 111 if their symptoms deteriorate. For the medium-risk patients, and some of the high-risk patients that perhaps are at 94% and do not desaturate, then we would recommend a daily phone call, and whether or not you can do pulse oximetry on them on a daily basis will be extremely helpful. So a lot of you will be able to access patients, access pulse oximeters to go into patients' homes, either by a mobile pulse oximetry service or bring them in for further assessment on a daily basis. And we would continue to monitor these patients until they're stable for at least 48 hours. If they do, if you are able to access pulse oximetry, then doing the desaturation test on a daily basis will also help determine whether or not patients are improving or deteriorating from day to day. Following on from this, we have a lot of discussion about what to do with patients in nursing homes. And as you have been hearing in the press, a lot of the concern is around about care home and nursing home patients with COVID, and we've given a lot more guidance about what to do with these patients in the community now, and that patients who have got suspected COVID should be tested if possible and should be isolated and monitored as you would do with a patient at home with COVID. But again, we would be recommending the use of PPE in patients with suspected COVID in the care home settings. So there is a much more extensive section on what to do with patients in the care home setting in this current guideline. section on PPE that's coming up here, this hasn't changed dramatically since section 3, because the PHE have not really updated their advice on PPE since version 3. They haven't changed their opinion on aerosol generating procedures, so they still consider nebulizers as not to be an aerosol generating procedure, although there is a lot of debate from the World Health Organization and GINA as to whether or not they agree with that. We also have some debate about cardiopulmonary resuscitation in primary care or in community care settings, and chest compressions. The Resuscitation Council suggests that this can be a potential aerosol generating procedure and do not recommend chest compressions in the absence of full PPE, whereas Public Health England say that that chest compressions are not a aerosol generating procedure, and that chest compressions are reasonably safe if you have a mask and an apron and gloves on. But they do recommend that you put a cloth or a covering over the patient's mouth and nose whilst you're doing the chest compressions, and that is in line with the Resuscitation Council guidelines as well. So really we would suggest that it is up to the individual practitioner to make a decision based on a risk assessment of whether or not the patient would benefit or not from this. And I think that until we get further guidance from PHE, that it's really very much up to the individual practitioner how you actually, what you actually do in these situations. But hopefully you're not going to be confronted with those very often. Following this, we have got the same section about advanced care planning and CMC records. Hopefully most of our patients that have got very chronic illnesses will have their advanced care plans in place already. So that's not changed very much. We have changed the treatment of patients with COVID because the NICE guidelines changed recently as well, so that we have now aligned our guidance with NICE, so that if you do face a patient with COVID and it's the likely cause of their symptoms, we are no longer recommending the prevention of secondary pneumonia. So previously we did say prevent secondary pneumonia with antibiotics, but now we are saying that you should only use antibiotics if there is a likely bacterial cause. Most of the time in hospitals, the coexistence of bacterial pneumonia is only about 10 to 20%. So it's possible that a lot of these patients may not actually need antibiotics. But if you cannot tell the difference between, if it's difficult to distinguish between a bacterial or a viral pneumonia, then we have also changed the antibiotics slightly to match what NICE have said. So the first choice antibiotic is doxycycline, and then the alternative is amoxicillin, and that the use of dual antibiotics, amoxicillin and clarithromycin, is not recommended. If the patient is allergic to amoxicillin or do not tolerate doxycycline, then clarithromycin can also be used as well. But we do not, again, routinely recommend the use of dual antibiotics treatments in this situation. So nothing much else has changed from the other aspects. Following discharge, there is some further guidance about what you would be expecting. Most patients that we are now discharging from hospitals, because there is no pressure on hospital beds, hopefully will be reasonably well. So they will not be hypoxic, and therefore there should not be a question about whether or not oxygen is required on discharge. So most patients will be discharged with an oxygen saturation of at least 94% and not desaturating significantly. So there should not be a concern about oxygen therapy supporting discharge from hospitals. We do have some further guidance on safety netting for patients on discharge, and this flow diagram here helps you determine exactly what is actually required in terms of the safety netting of patients and how we are making decisions about who is safe for discharge and what sort of follow-up they might need. So one of the factors that is important in determining discharge as well is whether the patient's in a vulnerable group, and they're going to need more safety netting than others who are not so. So hopefully most of our patients will be discharged reasonably well, and therefore should not need too much follow-up. But there has been some concerns which Sarah will go into during her session about what some of the complications that may follow a bit later on following discharge. So those are the patient groups, and hopefully not many patients are being discharged to interim care home or nursing home facilities, and ones that are requiring this, hopefully these are up to the CCG to actually find placements for these patients, but they should be isolated on discharge for a period of time until the confirmation that they are not have presence of virus on discharge. The current guidelines suggest that patients who are being discharged back to care homes or into care homes have a viral swab done prior to discharge, and that they are isolated until the results of that viral swab is known. Oxygen therapy, this has been slightly enhanced as well. The emerging guidance is that, again, we said that patients should not need to have oxygen mostly when they are discharged, but patients that choose to be at home for their treatment, there isn't a sort of a recommended pathway for this at the moment, but I think this needs to be done on a case-to-case basis. Oxygen can be prescribed on an individual basis, but I think that if this was the case, then I would recommend that you contact the COVID helpline in order to determine whether or not the patients will be suitable for oxygen therapy. But an oxygen concentrator can be provided at short notice if you feel that that is appropriate and patients have chosen that their home is their place for treatment. We have a very extended palliative care section, and it goes through the non-pharmacological treatments and also the pharmacological treatments in quite a lot of detail. So lots of guidance here about what symptomatic control can be used for patients that choose that are on the palliative care pathway. The only change in the business as usual section is that we are no longer advocating, again, the change in inhaled steroids in patients that are on very high doses of inhaled steroids, because even though there is a risk of community-acquired pneumonia in these patients, there is a risk that changing their inhaled steroid dose at this stage may actually destabilize their asthma or their COPD, and therefore we will do this. It's recommended that this be done after the COVID pandemic dies down. The appendices have been extended a bit so that we have the guidance on oxygen therapy in hot hub situations, about how you manage a patient who is hypoxic in front of you, waiting for LAS to attend, and how you can administer oxygen and what the dose of oxygen is required. So that's just a little bit of guidance about oxygen therapy. We have a bit more about how to use the clinical frailty score here as well. So sometimes this helps guide decision-making about whether or not a patient is going to be suitable for inpatient care or not. And this sort of helps the conversation about what may be appropriate escalation or the ceiling of treatment would be. We have additional pre-existing lung conditions with interstitial lung disease, obstructive sleep apnea and bronchiectasis. The only change here is that we have used the NICE guidance has recently come out and have said that the first choice antibiotic for treatment of bronchiectasis is now a co-amoxiclav of 7 to 14 days, and that you can get levofloxacin. If co-amoxiclav is not working, then the second choice is levofloxacin, but we would actually recommend that you phone the hotline first and discuss this with us before you go on to that stage, because especially since levofloxacin is not very readily available in the community at the present. We have a big section on how to implement coordinate my care records, and hopefully most of your patients who are at risk will already be on CMC at the moment. A very useful leaflet on how to manage breathlessness at home for patients. This is a patient information leaflet, and about how they can actually use non-pharmacological techniques in controlling their breathlessness. And finally, a really big section on the use of non-oral, non-parenteral routes of medication for the treatment of various symptoms if the patient is going to be managed at home. So that's the big addition to the appendix. As you can see, quite a very detailed explanation about the things that you can try to manage the various symptoms that you're going to be faced with in these patients. So that's version 4. Version 5 will be coming out hopefully early next week. So we will be sending you through the STPs a link or a copy through there. So hopefully you should see that in due course. Okay, so I'll pass you over to Sarah.
Hi everyone. While I get my slides up, I will just talk a little bit to you. It's been a better week in northwest London. We've had less cases of COVID, and actually I was on the wards last week, and it was a joy to see some of our really unwell patients leaving and going home, and I know they're really grateful for all the help they've had in primary care, with you picking their symptoms up, and also caring for them until they come to hospital. It's reassuring to see that actually many patients are coming off the intensive care units and they're able to go home, but they will need more care when they come back to the community, and we're trying to sort that out now. So I'm now going to move on to what questions we've had during the last week. I'm going to start with shielding. I think this is old news now, but it's just to really reiterate that there are many patients with respiratory illnesses that should be shielded. The two I'd like to concentrate on, though, and where confusion has been raised, is with severe asthma and severe COPD and what this means. When you read the literature, the definition of severe asthma in these cases is not those that have been to ITU, etc. It's those that are on biologics. It's those that have had courses or 2 or more courses of prednisolone. In fact, the data says 4 courses in 6 months. Also those that are on high dose inhaled corticosteroids, so the 200 dose of Foster, or the 400 of Symbicort, or 500 of Seretide, or the lower dose of combination with another drug such as Spiriva or Montelukast. With severe COPD, it's easier. It's all those that are on triple therapy, all those that are on long-term oxygen therapy, or really that are frail, over 70s, or on MRC 4 or 5. The rest of them should have been contacted by their secondary care clinicians. From the hospital, we sent out many letters as well, and I'm sure many of them will not have been missed. So any queries about that, please do ask us on the support line. We can still shield people at this late notice, although it's harder. So self-isolation was the next thing we're asked very much about. Who should isolate? How long for? They've still got a fever. The person's worried about coming out again. I mean, the bottom line is Public Health England still says that self-isolating for 7 days is suffice if it has had no further fever. Otherwise, the patient needs to have 48 hours fever-free before they need to come out of self-isolation. Everyone in their household needs to carry on isolating for a total of 14 days. So the most important thing is they need to carry on self-isolating for 2 days after fever has ablated. Repeat testing. So do patients who've had a confirmed swab need to be retested? No, they don't. So if their symptoms are getting better and they've had no further fever, they can come out of isolation. They do not need a further swab currently. Likewise, for patients we're sending home from hospital currently, we will do the swab. They will go back to a nursing home or go back home, but they do not have a re-swab currently. That may change again, but currently we say 2 weeks of isolation again on coming home after the swab. Ddimer, there's loads of queries about this, and of course this is because it's been in the press, and also there's more and more papers coming out of these. So the queries that we're tending to be asked are, Ddimer is mildly elevated in the context of symptoms such as breathlessness or chest pain. Do we need to exclude a PE? And the other thing, is there a role for Ddimer in patients with persisting breathlessness after developing COVID symptoms? Again, we all have to think about what we would do before the time of COVID. So if you really think that someone may be having a pulmonary embolus, so are they breathless, are they desaturating, are they tachycardic, then you need to take those symptoms in context, and that patient should be sent into ED. If there is a low risk for PE, then a mildly raised Ddimer is probably linked to the inflammatory phase, and we would not worry about that. So the bottom line is, if a history and examination is convincing for PE and more likely the infection alone, then really cross-sectional imaging is reasonable and they should be seen in hospital. So the next question is, are we seeing PEs in the hospital? Are patients coming in? Most of the patients that we're seeing with PEs have had severe illness. So they have been in hospital with severe fevers, hypoxia, hypotension, and unwell. We've had a few that have been readmitted before we sent them home with anticoagulation. We now send patients home with between 2 to 4 weeks of anticoagulation. From St Mary's, it's 4 weeks. From other trusts, you see it may be 2. So we look at the level of Ddimer before they go home, and we will recommend a NOAC for up to 4 weeks afterwards. So hopefully this will not be such an issue. The Ddimer may also be linked to venous stasis and not necessarily venous thrombosis, so please remember that. So it's taking the history in context of what the patient is telling you. Again, same theme, pleuritic chest pain recurring. So pleuritic chest pain can occur in COVID, and we're seeing it a lot, and we're having a lot of calls about ongoing odd type chest pain. If it definitely is pleuritic and it's linked to hypoxia and it's linked to hypotension, then of course they need to come in again. However, again, consider the whole history again, any recent imaging, any chest x-rays in hospital, CT scanning. And then a helpful thing is SAPS. If someone is not desaturating, it's unlikely again to be a large PE. If concerned about this pain, an up-to-date chest x-ray should be arranged. Now we're coming to the persisting symptoms. So as COVID is, as we're seeing more of it, we again are getting a feel for these symptoms and how long they go on for. Most symptoms with COVID, the average time frame is 14 days, but that's an average, and there will be people that get a lot longer, symptoms for much longer. So with cough, I think the most important thing is to make sure that it's not a bacterial secondary infection. So are they productive of purulent sputum? If it's dry, it most likely is post-viral and hypersensitivity, and that tends to get less. So if the cough is reassuringly lessening over time, that's reassuring and good. If there's no improvement, however, and they're coughing away and it's not getting better, then again a chest x-ray should be done to exclude other underlying pathology and to make sure your diagnosis is right. Again, red flags, hemoptysis, weight loss, night sweats, think of other diagnoses. And a cough alone is not an ongoing reason to self-isolate if they've had no further fever. Persisting fever, really odd, but we do, and we are hearing of patients that are having fevers ongoing for up to 6 weeks, we've heard recently. So is it due to COVID? Most likely, but please make sure there's no other cause for those fevers. So do you need to do bloods? Do you need to do cultures? Have they got a urine infection? Are there other investigations for red flags? Please note, across North West London, I mentioned it last week, we are seeing less TB. Are we missing it? Probably. So when are antibiotics indicated? Dr. Mack mentioned this, but really it's with cough with purulent sputum production or other suspected infections. Persisting breathlessness. So this is a bit of a busy slide, but I thought it was helpful. So patients do get exertional dyspnea after a severe viral pneumonia, and we are hearing more and more now people are surviving and getting on with their lives. So I've written in red here what we normally see with a severe pneumonia. So for 4 weeks, oops, let me go back again, apologies. So for 4 weeks, you might get muscle aches, chest pain, sputum production if it's a normal pneumonia. And we often say, don't worry, you can have symptoms for up to a month. What happens then? Well, for 6 weeks, your cough and breathlessness should have substantially reduced. And I would think the same for COVID. They might still be coughing and might still have breathlessness, but it should have reduced. At 3 months, most symptoms should have resolved, but fatigue can still occur with a pneumonia. And at 6 months, symptoms should have fully resolved unless the patient has had a complicated ITU stay. So in red is what we often say to people with normal pneumonias, and I don't think COVID is behaving any differently. So if symptoms persisting for several weeks with no resolution, consider requesting a chest X-ray if not already done. Patients are taking several weeks to recover, so breathlessness may persist, and also recommend that they pace themselves and they use breathless management, such as in the resource guide. And I think this website here, the Lancashire Teaching Hospital Recovery website, is excellent resource. It gives really good information to the patients and care workers. Please consider the need for referral for outpatient review if the chest X-ray remains abnormal. We're seeing in our recall clinic within St Mary's quite a few chest X-rays that are remaining abnormal, and we are going on to scan these patients. And again, if all recent investigations completely normal and no other clear cause, do explore potential anxiety. We're seeing more and more anxiety coming out as a result of COVID, especially if they have been in hospital or ED or have had a loved one that has been unwell. Falseness can occur with COVID. We're hearing more and more reports about this, but please exclude candidiasis, consider optimization of inhalers. Do they need an air chamber, etc., if they're using it? And if continues, consider a chest X-ray. Consider could this be related to reflux, and an ENT review should it not be resolving. Yeah, so Vince touched on this, the desaturation test. When should we be doing it and when shouldn't we? It's a really good test to do, and the guide, although it says should be done in a supervised care setting, I think if you've got hot sites that can see these patients, then that is a safe place to do desaturation tests. However, this is mainly a safe test. So if the sats are less than 96% and you're concerned about them, doing a desaturation test is fine. You can see them on your phone or your video consultation, or ask them what their sats monitor is doing. If the sats at rest are 94 or below, you need to have a little bit of caution. You need to know what their premorbid state was, whether they have any other risk factors for becoming more hypoxic, like ischemic heart disease. Look at their other indices, such as pulse and blood pressure, and balance the risk of doing one of these tests versus benefits of seeing them in the hub or even sending them to hospital. Steroids, we had a question just now about this. So can steroids be used for underlying asthma and COPD? The bottom line is if they are having an asthma exacerbation or a COPD exacerbation, then yes. But if you feel that COVID may be the cause of their symptoms and they have a fever, then please avoid these. So no fever, typical asthma, typical exacerbation of COPD, a short course of prednisolone is not going to harm and can actually help them. The other thing, people seem to be giving multiple courses of steroids. I really wouldn't advise that. You know, if symptoms are not improving despite prednisolone, then it's unlikely that giving them more steroids is going to help them. So please optimise their inhalers, speak to the support line, get a chest X-ray, think about whether there's any other cause for their symptoms that may account for their symptom. So, management of GI, again, a reminder that diarrhea can occur with COVID. It sometimes is the presenting symptom. So do think about, is this COVID or something else? We are asking people, if they're not clear whether it's COVID, to send stool samples and to do bloods to make sure the patient is not getting dehydration. Rashes, loads of rashes, and as I'm sure you've all heard, we're hearing more and more about Covid toes, those delightful things. So basically, yes, we think it is linked to Covid, and it seems to happen in the later stages about 2 weeks to 3 weeks, although some earlier reports have been in the literature. But they may be linked to microemboli, we're just not sure. We've also heard more and more viral rashes, and this seems to be a macular-papular rash that occurs in the majority of people that are going to get dermatological manifestations. They say that will account for about 40% of COVID-related rashes. We've also heard of urticaria and also swelling and angioedema that can respond to antihistamines. HIV has come up. You know, how should we manage people with HIV and COVID type symptoms? Usual investigations and treatment approaches apply, but we would highly recommend that if a patient with HIV gets symptoms such as fever or cough, you need to liaise with their HIV physicians to get a full history and know what their CD4 counts, etc. This could be something else as well. Referring patients to get assessed, can people now go to ED, ambulatory care or the on-call medical team? Absolutely. We want patients to come and be seen and assessed as normal. We have much better, maturer green and red routes within all hospitals now. There are some hospitals that are still busier than others. However, slowly we're going into recovery mode, and it will be very clear what we would recommend probably by next week. The most reassuring thing, though, but once patients come to hospital, they're generally triaged at the front desk of ED and sent to the appropriate, I should say, place. It looks like Palace, doesn't it? Should sent to the appropriate place. Safety of investigation. So again, I've mentioned getting chest X-ray. People they think, whoa, we can't send them to the hospital, that dirty place. The bottom line is consider what you would do normally outside of pandemic times. Think about the risk-benefit discussion with the patient and come up to a joint decision about sending them in. Again, radiology departments should be adhering to social distancing measures, and most have green routes. So if you want to do a chest X-ray because you think this patient has COVID, you either think this patient has COVID or not. If you're doing a chest X-ray because of another reason, then they definitely go green. Are we accepting referrals? Bottom line is yes, referrals are again being accepted, definitely within the community services and through ERS as well. You may have a bit of delay getting into outpatient review. However, this is now being recovered, so we're going through all the referrals that have been missed or not seen to date and are being prioritised into high priority, normal priority, and some may be discharged back to you with a request to re-refer if symptoms are still present, i.e. in respiratory we had quite a few referrals with cough. Many of those coughs may have now resolved, or a patient may think, actually, I don't really want to go up to see anyone or don't want to be seen on a video. Vince and I will be giving advice again via System 1 for those of you that refer in via inner boroughs. So follow-up in secondary care, it's important to highlight this to you. So some of the trusts now have begun to start setting up COVID follow-up clinics for patients discharged from hospital. So you may start seeing clinic letters about patients being reviewed in the next few weeks. This is really because in the immediate surge of patients coming in approximately 6 weeks ago, many patients were not reviewed with chest X-rays or symptoms since. Whilst LCW called a few of these patients, they did not call all of them, and we began to get concerned when a few patients came back still very breathless. So this is the last slide, just to say the last few webinars are here, so you can get them if you want to. We've also got other up-to-date things such as hypertension and diabetes review, which will be useful for you, and there are ongoing educational seminars quite weekly. We will be doing a very quick review of specialist COVIDs, probably again after the NICS reiteration, and in the interim time the support line will be open for you. So I'll stop there, and hopefully most of the questions will have been answered by Vince when I've been on that. Thank you for your attention tonight.
Okay, so I'm going to unmute Vince now, so you can look at the questions that haven't been answered. So the main themes seem to be chest X-ray, which you have covered, about that at the 5 to 6 week mark. There's a question on DOACs, and if they're being prescribed in secondary care, should we be doing the same in primary care? Lots about PEs. I know you've covered them, but it might be worth sort of covering that one more time. And Mahini Palmer's asked about the surges. So if hot hubs are currently quiet, when are we anticipating the next surge? So Sarah,
who knows? So it's Vince. I mean, I don't know how we can predict. It all depends upon when the lockdown is lifted, I suspect, and how well people are going to keep to the current lockdown at the moment. I mean, going out this weekend to the parks and just driving around on the streets, there seems to be a lot more activity going on. So I think that people are becoming maybe already a bit more relaxed about the restrictions already. So, I mean, I don't think we can predict when the next surge is going to be. There was one question that Sarah might be able to answer about chest X-rays. Apparently, Sarah, that the X-ray department's been refusing to do chest X-rays on people with persistent cough. Can you respond to that?
Please, mine. Certainly not when they've been coming from us. So please do let me know. I mean, it'd be useful to know which hospital that is in. I don't think St Mary's has been refusing chest X-rays with cough. They'd go through Red Route, and you need to be very clear on the reason why you're getting the chest X-ray. But I think they're really prepared to take more now. Certainly within Imperial Trust they are. If Northwick Park was put under immense strain in the beginning of this, so I'm not sure whether this was an issue there. Please do let us know which hospital this is, and we can take that up with them. As regards X-raying, yeah, I do think we with a normal pneumonia, we recommend a chest X-ray at 6 weeks to make sure changes have improved. Now, clearly with COVID, many of the patients in primary care have not had chest X-rays at the beginning of their symptoms, but I do think those that are in your category 2 high risk or low risk groups that have saturated down to 94% probably should be having a chest X-ray at some time to make sure they don't have ongoing changes. Reassuringly, most of the people, we've seen now approximately 52 patients within the last 4 days at St Mary's with repeat chest X-rays. Probably about 70% of them are improving, but we do have about 30% that are staying abnormal, and this was very similar to the SARS-1. So if people have persisting breathlessness in the community after their presumed COVID, or they're having persisting cough, then I would recommend a chest X-ray, yes. As regard PEs, one of the questions was, should we be recommending or thinking of giving NOACs in the primary care environment? Vince and I have spoken about this, and we brought it up at London Board. I really think that if you think someone needs a NOAC in primary care, they really should be reviewed. We wouldn't be asking you to give a NOAC for a PE without getting a scan or without getting reviewed by a secondary care clinician. So please don't change your practice too much. I think the evidence currently is that these patients should be reviewed and decided. It's an ever-changing bag, isn't it? But currently we would say these patients need to be discussed and reviewed. So no recommendation currently for primary care to start NOACs. Yes, we are giving it on discharge from hospital if the D-dimer remains above 1,000.
Wonderful. I think that's most of the questions answered.
Sarah, can you just remind people of the hotline number?
Yes, so the hotline number is 0203 331 4488.
Is it 311, not 331?
0203 311. That's correct, Vince. 4488. I'll repeat that. 0203 311 4488. Lovely. Any other queries? There's also, just to say that the advice line, the respiratory advice line email is still going. It tends to be answered twice a week, so not for urgent things currently, but we will get back to you from that as well. So that's respiratory. I
think it's worth saying that the hotline is for COVID and non-COVID related respiratory problems.
So we'll take general respiratory queries on that line as well. Yes.
And what time does it run to, Sarah?
It runs from 9 to 6, 7 days a week.
So people have been calling up to 7.
They have been calling up to 7. And if our phones aren't turned off, you might get Vince or me. Good luck. That'll be fine. We will. But so if we're still there, then we'll answer. But it's definitely on a serious note. It's definitely manned 9 to 6. Yeah.
Wonderful. So thank you very much, Vince and Sarah. So we'll close the webinar there. If you can complete the Mentimeter, www.menti.com, code 987890, and submit your feedback, that would be absolutely fabulous. And if you also want to submit your emails, we can send the typed up Q&A and the slides your way. Thank you very much.
And thank you so much for your attention, and thank you for your support of the Secondary Care Trust too.
Thanks.